Another quick reminder, go after this, and then the QR code for attendings for CME up front. So it's my pleasure to introduce Dr. Reid Oldenburg, whom I believe most of you know better than I do. He's one of the UCSD and VA attendings, was chief resident during his time in derm training here, received his medical doctorate from Case Western, did his PhD research in immunology in Paris, and before that, triple majored at Tufts. As an early faculty member, he's already made significant contributions to the derm literature. Things you may not know about him, though, include his award from the Harry Resnick Memorial Fund for Unusual Achievements. I'd love to hear exactly what those were. He won the Outstanding Care and Compassion Award in his prelim year. He's on the editorial board of a Sultan's medical journal, and he's fluent in 3 languages. In my short time here in San Diego, I've already heard him speak 3 times, more than anyone else since my arrival, and I've been impressed with not only his breadth and depth of knowledge on the subject matter he's speaking of, but also his relatability and ability to convey the salient points of his talks. I'm sure his talk today will be no different. Thanks, Dr. Oldenburg.
All right, nice, thank you. So we're gonna try and be out of here by 11. So I'm gonna set a timer, and then if you don't mind, just give me a wave or give me the cane when if I'm starting to talk too much. Thank you so much. Specifically knowing that this is very clinically oriented, I split the talk into 2 separate sections. So we're gonna definitely jump into some of the RIME clinical latest research, and we have pediatric dermatology faculty here. So your input will certainly be appreciated as well, but I'll do my best to review all the clinical paradigms and then talk about some of the latest research that we're doing. And of course, I want to first try and advance the slide. I want to thank you all for providing samples or letting me know when patients are here. It's really, really helpful. We're focused on RIME today, but everyone who's been telling me about the SJSTN and DRESS cases, it's been very, very instrumental, so thank you for that. I don't have any relevant conflicts of interest to this talk. So the outline today is we'll go through some of the clinical paradigms of RIME, focusing on the differential diagnosis, some workup and management pearls as well, and then going into some of what is happening on an international level with clinical research and certain questions that still need to be addressed in the field. And then we'll go into some of the later basic science to try and close some of these gaps or try and address some of the gaps in understanding treatment paradigms better to sort of plan the next few years of what we can do in the field and how we can support in the improvement of clinical treatment paradigms. And then we'll focus specifically on a case of RIME that we did some basic science correlation with, and then go into what the future may hold for this. So I always think, having a case-based approach is really valuable to sort of remind us of how to look at these patients, but also when we're seeing these patients to think about what is lacking in the field and how we can address questions and improve care further on, because really a lot of the research questions that we subsequently ask are ones that are brought forth in clinical discussion. So this is a case that was, the attending was a former Reid's fellow. This is Jenny Mancuso, saw this patient who's 17 years old, and after 7 days after having COVID-19, developed a progressive mucositis, ocular discharge, sore throat, muffled voice, and painful swallowing. So of course, the title of this talk, so the diagnosis, but the differential diagnosis, similar to how we would present some of these grand rounds cases, is of course reactive infectious mucocutaneous eruption, or RIME, is on there. Certainly a Stevens-Johnson syndrome, a DRESS SJS overlap, Kawasaki's disease. All of these different these different diseases must be considered. HSV, a horrible mucocutaneous HSV, could potentially present like this in immunocompromised hosts, or HSV on top of any of these conditions. Erythema multiforme, of course, hand, foot, and mouth disease, fixed drug eruption, and then some of these immunobolus diseases that were excellently summarized this morning as well. Paraneoplastic pemphigus now now in the literature is starting to be referred to as paraneoplastic autoimmune multi-organ syndrome. So that's a good differential diagnosis. And for those of you who are sometimes struggling to identify the true diagnosis. And I think it is really important to pay attention to the evolution of the patient and have an appreciation for if you are earlier in the spectrum or earlier in the presentation of the disease, it may be more difficult to delineate between these different diagnoses. And so, of course, we do often rely on a multidisciplinary team. We have to call upon our infectious disease colleagues, sometimes the Kawasaki disease specialty service and rheumatology to help parse these out. But from a larger perspective, Kawasaki's disease typically is non-erosive and non-bullous, and these patients typically will have a persistent fever and will have more of a desquamation of the hands and feet. Of course, if there's atypical Kawasaki's or if it's an earlier presentation, this will definitely need to be on your differential diagnosis as you're following these patients. When it comes to Stevens-Johnson's disease, typically the medication timeline will not match, and that's why dermatology is really critical because we have a really acute understanding of how important these medication timelines are. Of course, there are typically some confounding factors, and when you're getting the history, sometimes the parents and the patient are very tired, and oftentimes NSAIDs have been used, so this can definitely make the differential diagnosis, sorting through the differential diagnosis more difficult. DRESS and SJS overlap, I've added to the list, but of course there'll be some differences in laboratory, and of course the history of the drug timeline will be critical. HSV, I think you always need to consider no matter what. I think all these patients, if they have an erosive dermatitis, should have a PCR swab, so this will definitely enter into the calculus. Of course, HSV can also trigger RIME, so that makes it a little bit more difficult. Erythema multiforme, you can argue that this is on a spectrum with RIME, but typically morphologically, erythema multiforme will not have any mucosal involvement. And then hand, foot, and mouth disease, I think, can also be somewhat difficult, but a lot of these patients will have more macules and papules and have more of a morbilliform eruption. And of course, the palmar plantar involvement is a clue. And these patients typically don't have ocular lesions. But I think a caveat here is that if a patient has eczema coxsackium or some horrible eyelid dermatitis that's potentially allowing a window for infection, then these patients can have blistering around their eyes and make it more difficult to detect. And of course, this is where microbial testing is critical. Fixed drug eruption, I think it came up multiple times this morning, so we can not include that, but that typically does have dusky lesions. And then I think pemphigus vulgaris and perineoplastic pemphigus will typically have a different onset in timeline. So some of these cases of RIME will be recurrent, but definitely that slower smoldering onset is something to watch out for. So asking about the duration of these lesions is really critical. But oftentimes, and if biopsies are going to be performed on these patients, it's very reasonable to include a DIF because sometimes it is definitely difficult to distinguish between these. But definitely have an open mind with these patients and be willing to reassess and do not anchor because things can evolve, and that's why following these patients closely, of course, is critical, but also having a good sense of what return precautions should be. So if these patients are calling in with lesions, having return precautions is critical. So we don't have to go into too much detail about this case, but this case of this patient had an elevated CRP and was treated with a combination of IV methylprednisolone, a really intense course of IV methylprednisolone, was initially discharged and then represented theoretically because there was a lack of response to systemic steroids and was retreated with IV methylprednisolone and cyclosporin. So this was a very complicated hospital course, but of course, fortunately, the patient did well without any sequelae. So this is, of course, RIME or reactive infectious mucocutaneous eruption. So the workup, I think I've alluded to in some of the elements of the differential diagnosis and avoiding anchoring on different diagnoses. But of course, history and physical exam is always the first approach. Sometimes, of course, you want to take the stethoscope or ask the intern or the medicine attending to carefully do a pulmonary examination, but you can, of course, try and capture elements of a history of mycoplasma pneumonia, asking about, different air conditions, different exposures, different people that may have walking pneumonia. So, and I think walking pneumonia is a good history question to ask these patients because people, of course, know what that is. Ordering a chest x-ray is usually done in the ER, but something to consider. And then fortunately at Reid's, there's really, really high exposure or a lot of use of the respiratory pathogen panel in the emergency department, but especially for adult patients, I've noticed that some ER patients do not actually receive this. So sometimes in dermatology, I'm sure you've worked with me, you have seen us recommend ordering a respiratory pathogen panel. So I think in the adult patients, we see this less frequently, but certainly in rabies, our colleagues are ordering this more frequently. When it comes to mycoplasma labs, of course, the IgM is commonly ordered. I think it's hard because there's probably some exposure in the community to mycoplasma in general. So sometimes what you can do is you can recheck an IgG on admission and then after discharge and look for a full four-fold titer increase, so about 4 to 12 weeks afterwards, and that can give you a little bit of a clue in conjunction with the history. PCR is definitely possible, and I've seen it used at other institutes. Have our attendings, Dr. Tom or Dr. Shire, do you order mycoplasma PCR? Have you had a chance to get some of the mycoplasma swab done ever? Right, it's on the respiratory panel. So fortunately, that is something that will improve your capture rate. But using this combination of serology is very valuable. And then I would argue, and certainly correct me if you disagree, but I would argue that checking an HSV PCR of the mucous membranes, especially in areas of erosion, is definitely what I would do in adult patients for sure, including patients with pemphigus and other mucocutaneous eruptions. Typically on admission, I would also recommend, since TNF inhibition is a very important treatment algorithm, ordering labs in preparation for potential use of TNF blockade. It may happen subsequently after discharge, even if patients have recurrent episodes of RIME. And then I think there's a lot of discussion or interest in potentially adding other viral or other testing. But I think using your history always to help guide some additional microbial testing is very reasonable. And then, of course, using your physical exam to look for overlapping features, maybe like a Lipschitz ulcer or something like that, would make you think more of some of these viruses that can cause mono. And then in some patients that are very sick, especially if they're intubated and require bronchoscopy or they're closely followed by ID, you could make a case for getting a Carius. So next generation sequencing to look for other pathogens. And then, of course, if there is access, if the patient is intubated, then consideration for a bronchial or alveolar lavage with broad and infectious workup should be performed. But fortunately, infectious disease does a very good job of casting a very broad net to capture important microbes. Cytokine labs, I'm going to make the case for today, and I also am going to make the case that we add cytokine labs to our UCSD labs. So if you ever interface with our UCSD staff, you can try and convince them to add specific cytokine labs so that we can get this testing more rapidly. And I think having a discussion with our Radies lab would also be very beneficial to identify this. And I think also, as an aside, I think we're probably going to need to get in-house testing for measles soon, because I don't think that's available at Radies. I know at UCSD there's no measles testing that's available in-house, so that's still a send out. So I think we need to continuously push the envelope and try and improve access to high value molecular testing. Management, I think, I don't need to go super in depth about management, but of course, supportive care is super important, but also education and explaining things to the patient is critical. And so having clear return precautions for your patients and having a low threshold for hospital admission, especially if there's not good PO intake, you don't want these patients sitting at home not able to eat for multiple days, because then they're at risk of having refeeding syndrome or other bad things happen to them. So certainly having a clear educational approach with the patient is critical. Of course, we rely on our emergency department colleagues to have a good sense of what requires hospital admission. Of course, they do a fantastic job in that respect. And I would, certainly put a coin down and say that, empiric therapy is very reasonable. So azithromycin, especially if there's a history of exposure or walking pneumonia or any symptoms thereof. And then if the patient does have a history of HSV or has a history of fever blisters, I think starting empiric therapy with valacyclovir, of course, evaluating mucous membranes and even considering IV acyclovir in these patients is reasonable. Nutrition is an active debate, but I would definitely suggest, especially in patients that I see on the adult side, getting nutrition consult for mucocutaneous eruptions is very valuable. Even, sometimes patients, They don't realize that they can actually eat soft foods. It's something as simple as that. But of course, NG tubes, and more research is needed, but of course, NG tubes are being used more aggressively at other institutes to provide nutrition and allow, of course, mucocutaneous areas to heal better. And then, of course, oral care, we all know because we manage this in patients with pemphigus, et cetera, but using a combination of different things for healing. But particularly in the literature, in pediatric RIME, it is very important to evaluate the oral commissures because the patients, I think mostly, I would say a lot of the adolescent patients, they may actually stop even opening their mouth. So you're at risk of causing scarring of the oral commissure. So some of these patients will benefit from having impregnated gauze put on the corners of their mouth to prevent it from not scarring. So that is something that's been mentioned typically in the literature, and really want to be putting tons and tons of emollient on the mucocutaneous areas to avoid crusting and additional scarring, et cetera. I'm definitely not in a position to talk about ophthalmologic and urologic care. So certainly, especially in pediatrics, I would recommend a very low threshold for consulting and evaluate these areas on a daily basis. It's very important. So if these patients are not following you, or if on the adult side, the service says they don't want to follow the patient, or they recommend reconsulting if there's changes, then it is very important to continuously look for these changes in patients. And that goes beyond just RIME, but other mucocutaneous eruptions. And then skin, care, it's very similar to SJS and TN. We don't necessarily recommend debridement unless there's severe infection. Immunomodulatory therapies I'll get to, but talking about counseling these patients, and of course having psychology, access to psychology is really important. So, I mean, this is a little anecdotal, but I would definitely recommend against scheduling these patients on Friday afternoon. I would probably bring them in the morning so that you have resources there and psych to help address some of these, some PTSD that can occur in these patients. So let's get a little bit more into some of the details and some of the nuances. So going back historically to 1922, if you look at the original Stevens and Johnson's report of SGS, this patient was 7 and had a clear bronchopneumonia. And I can't remember, but I think one of the parents also had that, but this patient presented with bronchopneumonia and then subsequently developed fever, rash, conjunctivitis, which unfortunately led to corneal ulceration and blindness. But this patient actually may have in fact had a case of mycoplasma pneumonia, so a MRM or a RIME presentation. And of course, 3 years later, most people in the audience have definitely read this article, coining that actually is the originating article behind the term mycoplasma pneumonia-induced rash and mucositis, or MRM, that was very important before the emergence of the term RIME. But I think this reference in this article is definitely landmark because it describes some of the key features of MRM or RIME, whereas less than 10% of the body surface area is involved, greater than or equal to 2 mucosal sites are involved, and then there aren't many atypical targets or targetoid lesions in these patients. But of course, there's, like I said, there's definitely overlap between this. And then of course, the workup is listed here below. So definitely read this article. Unfortunately, sometimes presentations of RIME, especially in the earlier or in the recurrent setting, do not have 2 mucous membrane sites involved. But definitely, I think this is a very good a resource for our residents and learners in the audience as well. Reactive infectious mucocutaneous eruption was born out of the Pediatric Dermatology Research Alliance, and a group of researchers put this term together with Michelle Ramin to coin this term that has now gained traction and is being used very frequently in North America, less so in across overseas. And the list is still growing for potential triggers, with, of course, COVID-19 being added to this list. But of course, mycoplasma pneumonia really takes the lion's share of the amount of triggers, and it typically is easier to detect. So I think that's probably informing us better. And then, of course, it's difficult to prove causation between these triggers, so more basic science is required to understand this. But these viral and bacterial pathogens in this list have all been mentioned to be associated with RIME. So it is hard to prove causation, but they definitely are very important, and working these patients up is critical. So when it comes to treatment selection, of course, we talked about the importance of supportive care, but using different immunosuppressive therapies is very important. And this is why, once again, the education of these patients is critical so they know to present earlier, and then having a sense of what the clinical timeline of these patients are. So if a patient has erythematous lesions and not necessarily just dusky or hemorrhagic crusted lips, those are the patients you want to identify faster. And so this is why, having clinical research to talk about ways that we can interface with our colleagues in the emergency care department and understanding some of these red flag features so that these patients can get a consult earlier is also important. But of course, having this sense yourself as a clinician and looking at these patients and looking for erythema, looking for advancement of lesions is very important, because that's going to guide the way that you use immunosuppressive therapy and even consider redosing these patients, or even considering patient failure. So I would say it's super important to have a good sense of this, because if the patient is presenting very late, 2 weeks later, having an aggressive intervention, especially in the context of a severe bacterial infection, could lead to some significant morbidity. And that's something that you should definitely try and avoid and weigh these options. Of course, we do rely on our infectious disease colleagues to help guide immunosuppressive therapy as well, but we still have a lot of work to do. But TNF blockade is certainly now leading at most centers as the treatment of choice, but some centers still in North America are only doing supportive care, and then other centers are more aggressive, using a combination of systemic corticosteroids, cyclosporin, and TNF blockade. So definitely some variety. This is a very valuable article, especially for the learners as well, because it really shows the power of a case series and how that can affect the way that we alter treatment paradigms at institutes. And then we actually use this article to get etanercept put on the formulary at RIME, at Reid's. So this was a retrospective cohort study of 6 patients that were treated with etanercept, and there was an improvement in the length of stay of hospitalization, and patients also had an evidence of response within 24 hours of treatment, and the dosing is 0.6 to 0.8 milligrams per kilogram. So you might see that even in adults. Sometimes your adults weigh 40 kilograms, by the way. So it is important to remember weight-based dosing, of course. So can we improve treatment algorithms? Can we extrapolate from what we know about SGS and TEM? Can we compare that to RIME? We need more research, both clinical and basic science. So, PEDRA has really opened a lot of doors for me and really has given me access to a lot of bright minds, a lot of really bright clinical minds. And I think what's specifically special about PEDRA are these focused study groups that are created, and the Drugs and Bugs has an important focus on RIME. And having people in a room together is very amazing, because there's clinicians that see high volume RIME, and they're pretty much asking questions that they are informed by from large patient volumes. So there's a lot of important questions that are shared here, and a lot of research comes out of this, because unfortunately it's hard to do research in such rare diseases, and having a multi-center approach is critical. So the Drugs and Bugs committee is really, really valuable. Some of the ongoing projects that are happening in the Drugs and Bugs group are doing an additional case series of etanercept-treated RIME patients, using genetic whole exome sequencing to identify RIME patients of trios, so patients with their parents. So this is being done in a multi-center group as well. Consensus building is ongoing as well. Of course, that is evolving as we know more about this disease state. Deciphering the immunopathogenesis is I would argue, one of the most important aspects to guiding future therapeutic choices, and then assessing the utility of NG2 placement. But certainly there's opportunities for those that may be listening who want to work on this. There's opportunities for continued projects as well. Of course, there's an extensive administrative hurdle to working in a multi-center way. So for leadership, I think it's critical that we identify ways to sort of facilitate multi-center studies, material transfer agreements. I think we all need to do better in terms of facilitating ways to make centers work together. I'm going to do a quick time check, so it's 10:30. So I cut a few slides in the interest of time, but I definitely want to get into some of the basic science components and draw parallels between SGS and TEN because, of course, morphologically, these are very similar. And so the immunopathology of SGS and TN, of course, has now advanced in the setting of additional molecular testing, but certainly having single cell transcriptomics has really created more information around this. But some of the state of the art right now is that we know that there's a drug antigen interaction between antigen presenting cells and CD8 cells, and probably also keratinocytes that are presenting antigen as well. And the CD8 T cells are pretty central in creating a pro-inflammatory environment, but also creating or producing cytotoxic mediators like granulysin and perforin and granzyme B to directly kill keratinocytes. But if I had to really take a guess, I think a combination of the cytokines along with these cytotoxic mediators is more important for killing the keratinocytes, and there's probably a dose, a critical dose that's needed to actually start this massive cell death. And looking at keratinocytes, MLKL, and necroptotic cell death pathways seem to be most implicated in the death of the keratinocytes. And so this is specifically for SGS and TEN. Recently, and a lot of you have sent me this article, so thanks for sending this article. But recently, of course, in October, there was this very important Nature paper describing using spatial proteomics, so looking at proteomic signatures and affected different cell types, including CD45 positive cells, but also keratinocytes, and looking at some of the pathways. And just to save you some of the details, definitely worth reading this paper, but interferon alpha and beta and interferon gamma, so both type 1 and type 2 interferons were implicated in some of the proteomic changes that were seen in the skin. And then the researchers went on to check phosphorylated STAT1. So STAT1 is downstream of JAK1 and JAK2, which is downstream of type 1 and type 2 interferons, or TYK2 would be from interferon alpha beta. But having STAT1 phosphorylation is indicative of very importantly, interferon gamma signaling. And so using immunohistochemistry, the researchers in this group looked at phospho-STAT1 expression, which of course, we would want a dermatopathologist to review this, but it definitely looks like it's increased in this pre and post JAK. So after JAK inhibition, using a combination of different JAK inhibitors, but most of the JAK inhibitors block JAK1 in this study, the levels of phospho-STAT1 were decreased. And the patients, it was a very heterogeneous group of patients that were presented in this paper. Some of them were on checkpoint inhibitors, so I think there's a lot of differences in immunopathogenesis in these patients, but the short version is that JAK inhibition seems to play a role in reducing this expression, but also you can argue, and we haven't seen this in a controlled research setting, but you can argue that JAK inhibition is going to be a valuable addition for these patients. Elizabeth Phillips' group in parallel did single cell RNA sequencing from skin samples in patients and identified CD8 T cells. We don't have to go through all the genetic signatures, but the cytotoxic mediators were confirmed in skin samples, specifically from CD8 positive T cells. And then it was reassuring, not only are we seeing JAK-STAT signaling in these T cells in the affected skin, of course monocytes and K cells as well, but there is also evidence that TNF is being altered from a transcriptional profile. Of course, we're here talking about RIME, so we should focus back on RIME patients, because what if RIME is actually not really SJS and TEN, or what if it doesn't overlap with it? What if it's similar to a sort of variant of lupus where high levels of interferon might be driving mucositis? So we do need to understand this a little bit more. More research is needed, but I'm able now to present some data from 5 patients that we were able to get, and I think of course, RIME in a lot of ways is difficult because you have different pathogens that can trigger this, and sometimes we don't actually know. But the 5 patients that I can include in this series to present to you today did have different pathogen triggers. One patient was unknown, but we had an adenovirus case, mycoplasma pneumonia and COVID, and then another patient who had recurrent RIME from mycoplasma and had multiple presentations. Since this is, a grand rounds talk, I'll specifically just say we did multiplex cytokine analysis using oligo-based antibody staining. So it's a way to address many different cytokines at once. And if you plot out all of these different cytokines and use a variability measure statistically, you can plot all the cytokines from different patients. So here are the 5 RIME patients, and it is definitely somewhat reassuring to see, even though there's different triggers for this, and there's probably scientifically, there's probably some variability between these patients, there is somewhat of a signature that's starting to emerge from this. And we do have 11 patients that we plan to rerun this analysis on, so more patient samples are needed, but we are seeing statistically, when you plot this together, we are seeing an emergence of some important biomarkers, I would say, maybe not necessarily to drive therapeutic choice yet, but I think these are some emerging biomarkers that can be helpful. So CXCL9 and 10, interleukin 27 and IL-6, I think are valuable. And then cytochrome C is just a marker for mitochondrial damage or a type, mostly a lot of apoptosis. So I think that's needs to be taken into consideration. But CXCL9, I think, is the most exciting biomarker of this list. If you all were here 2 years ago, I presented some data on this case, which was a patient who had more of a toxic epidermal necrolysis presentation without a known trigger. So unfortunately, we never found a pathogen trigger. We never found a drug trigger, but the patient did not take any medication, so we assumed that it was likely a pathogen trigger. And this patient did have also very, very high levels of CXCL9 and 10. I also was able to test blister fluid, and the CXCL10 levels were just really through the roof. Going into a brief summary, specifically focused on biomarkers, CXCL9, 10, and 11 are emerging as valuable biomarkers, and this is seen also in SGS and TN that's triggered by drugs. And these are typically associated with type 1 and type 2 and interferons, but CXCL9 is more thought to be triggered downstream of interferon gamma, and our allergy and immunology colleagues who, Hal Hoffman and Lori Broadman explained the cytokine to me very well, but our immunology and allergy colleagues use this to guide potential use of a monoclonal antibody that targets interferon gamma. So this, I think, we're seeing has traction in other specialties, and I would like to make the argument that CXCL9 could be a valuable biomarker for us, not only for RIME, but potentially for SGS and TEN. So what do we do next? I think we've been able to get some peripheral blood mononuclear cells from some RIME patients. I have about 11 patients, but there's only one patient that we were able to actually perform the entire analysis on. And so we're still working with our bioinformatic team to identify important interactions, et cetera. So we're still honing into this data. And I think the ability to analyze this data set will help us with subsequent data sets. But this patient had adenovirus triggered RIME, and the adenovirus was identified in a bronchial or alveolar lavage because this patient was very sick. And this patient developed a presentation that was morphologically consistent with RIME and had a very complex hospital course. So a lot of you know this patient in this room, and this patient was followed by multiple specialties and subspecialties and required or received a variety of different immunosuppressive medications. So very high dose methylprednisolone, 2 infusions of IVIG, which did not seem to help too much. And then the patient also received etanercept on 2 separate days. We sequenced using single-cell RNA sequencing samples from active, treated, and recovered. I'm going to not spend too much time on this data, but we'll get into some of the what we saw in PBMCs, which is if you have not looked at single-cell RNA sequencing data much, the simple explanation is that you sequence the entire transcriptome of each individual cell, And then what you do statistically using a method called dimensional reduction is you compare all the cell types to one another, and then they cluster together based on their profile. So it's very reassuring when you see that cells have these separate clusters, because that means that statistically or through informatics, you're able to identify key differences between these cell types. And then using what we refer to as canonical genes, so for example, CD3, we look at expression of different markers that are unique to different cell types, and then we use these canonical genes to properly annotate cell types. So that's important because then we can really interrogate these individual cell types and try and understand which ones are key players in disease pathogenesis. And I know this is only one patient, but we were able to plot out, since we had 3 different time points with the patient serving as their own control, we were able to plot out some of these differences at these different time points. And no obvious changes were really seen on the large, multicellular level. So of course, the next thing to do is focus on different cell types. With T cells, we know are important, of course. So looking at T cells, you can do a subcluster analysis, very similar to what I said, using software to split apart the different cell types, annotate them, and we did not really see much. I went back on a slide. We did not really see much differences when we plotted this out. So I'm going to save you the details of plotting out volcano plots and pathway analysis. But since we're focused on monocytes, we know that monocytes are key parameters, but we focus on monocytes next, and we subsequently plotted these all out and annotated them and identified different monocyte clusters. And if you plot these out between active and recovered, you can see that there's differences very clearly in these monocyte clusters. And this is only one patient, so this is preliminary data. But of course, classical monocytes versus non-classical monocytes, there's differences in inflammatory profiles, and non-classical monocytes, which are absent in RIME, are thought to be more anti-inflammatory, whereas classical typically are thought to be more pro-inflammatory. So of course, these are very large generalizations of the patient data, but if you focus specifically down into classical monocytes, which we think are important in this specific patient, you can plot out all the different genes, and you see a large difference between active versus recovered. So these monocytes are very active in differences in RNA. And this, for a basic science talk, this would be important because we would be identifying these different markers and following up with them with functional assays. But from a clinical standpoint, you would certainly ask what is actually what is actually valuable here. And the way that you can sort of try and glean clinical information from this large data set is you can do an unbiased pathway analysis and use software to identify different markers. And so TNF alpha signaling is fortunately annotated to be altered in these monocytes, as well as IL-2 STAT5 signaling. So this is a nice guide, and we're now working to generate heat maps to specifically interrogate different interferon pathways, because our goal eventually is to use these annotated pathways to guide our understanding and focus on ways that we can care for these patients. Continuing on this idea of pathway analysis, if you do an interferon interrogation of these pathways, you can identify different type 1 and type 2 pathways that are altered in these patients. So of course, this is one patient, but certainly we have a lot of leads to follow and a lot of biomarkers to chase after, but clinically there's a lot of valuable things. So FKB51 is going to be a target that we can look at because that was altered in many different cell types, and we can do now some ex vivo work to look at the value of this, and this can potentially explain for why some patients don't respond to corticosteroids. So a lot more work is needed, but I think I just wanted to quickly go over some of the basic science that we're able to do, because I think with additional funding, we're going to be able to analyze more samples and focus on ex vivo work to guide this. But overall, we now are able to draw some parallels between SGS and TEN and implicate TNF and interferon signaling in these patients. And I would make the argument that CXCL9 is a viable exploratory biomarker for these patients. And using single-cell RNA sequencing on one patient, we're able to get a sense of some of the dysregulations that is occurring, and we're confirming a likely important role that interferon is playing in these patients. And we need to do more work for sure. So in going back globally and looking at the overall lay of the land for RIME research, this is not research that I'm going to be able to complete alone, but this is done in conjunction with different partners across North America. But collecting Mycoplasma pneumonia samples, I think, would be a very valuable approach. Doing multi-center clinical research to identify deficits in what our treatment paradigms are, and then create similar to maybe what we do in rheumatology, where we have plan of care design. So there's different pathways that we can go down. Of course, this was going to require a lot of information from what we know in a retrospective perspective, but also some basic science to help design these avenues of research. So that is definitely going to be an important thing that will be done on a larger scale. More sample analysis, which I've described, is definitely needed. And fortunately, spatial transcriptomics will help us go back into old archives and look on the tissue level and identify pathways. And then using more sophisticated and more hypothesis driven questions, we can use some samples from patients and start to do ex vivo. So it is critical that we continue to recruit these RIME patients to understand what's going on. So it's 10:45, and I think it's always nice to think, as an audience member, I would always say, well, what can I do, or how is this actually going to change the way that I approach things, and what can I do? I'm a resident or I'm an attending, what can I do for these patients? And I think, certainly all of the didactic information and reviewing all the articles is critical, but when you see these patients having detailed records and having standardized patient data is valuable. So currently in the PEDRA group, we're now starting to share what other providers are doing and have a standardized workup or a standardized questionnaire that we have for patients. And so I think there's a lot of progress we can make for getting higher value clinical data. And then, of course, ordering appropriate testing to try and identify the culprit pathogen is valuable later on, but of course it can guide your antimicrobial therapy. Taking good pictures, always good, especially in these hospitalized patients where it might not be so easy. It is valuable later. And certainly while the patient's hospitalized, it's good to be able to follow things. You may be switching attendings or switching residents, so it's really nice to have nice photos to track the progress of these patients. And I think there is a case for ordering, potentially ordering cytokines on some of these patients, because I think in the future, we may have a short list of pertinent biomarkers that can help guide our therapeutic choices in these patients. And I certainly have used CXCL9 TNF recently and addressed SJS overlap patient, and I think it was actually very helpful for guiding our treatment choices in that patient. And please continue to notify me if you have patients. Just let me know, just send me a text. You don't have to tell me all the information, just tell me, hey, there's a patient, or maybe tell me like the age or something, that's it. Just say there's a patient and I'll take care of it. So I won't call you and I won't ask you a million questions about the patient because I know you're busy and you're on call. So just tell me that there is one and I will look into the patient. I really appreciate it because this research would not be possible without a group effort. So thank you all. And I've had an insane amount of mentorship from allergists and immunologists, people in our department, of course, and then internationally, I've had a lot of mentorship from members of PEDRA. And then down here, I have different groups that have been funding me, but I'm also mentioning the NIH because the NIH indirectly has provided me an unbelievable amount of training. So I really love the NIH, of course. And then, of course, I work with Ben Croker in his lab, so lots of colleagues that I work with in the lab. So thank you, everyone. And I will stop there because it's 10:48. Okay, we'll give you a microphone. So the question is if I want to know about patients after the fact, and yes, it's always good to know because I can add them to a list, and then I can share the list with later on if we're doing retrospective chart reviews. I can share it with Don field, and we can work through the data. So it's always good to know. And sometimes these patients will have recurrent cases. So sometimes I can have a better radar on these patients. And it is always good to know. I always appreciate knowing. Yeah.
Reid,
Yes.
thanks for a great talk. And I'm really proud of you that you are not settling for the anecdotal dermatology that so often is used by all of us because of lack of understanding the pathophysiology and driving better understanding of the pathophysiology. So great work, and hard, very hard to do. So you should also be congratulated for taking on a difficult problem. A couple comments.
Thank you.
There is a drug in clinic now, not for derm at all, that targets the receptor for CXCL9. And since it is such a potent T cell and monocyte chemoattractant, and most of the CXCL9, we believe, is actually released by dermal fibroblasts, using the CXCR3 antagonist might be it would be an interesting test of your hypothesis. It would suggest that CXCL9 is not only a biomarker, but it's actually critical to the pathophysiology. Will have less potential side effects than just targeting interferon.
Mm-hmm.
So if that's at all possible for you to look into, it's been in clinical trials with cancer, because that's where the money is. So drugs get developed that way. It's been shown in diabetes to have some effects. We're playing with it in mice.
Hmm.
We can always make mice better, but just an idea for you. And then
Yeah,
the other
fantastic.
piece of information is that, more than 90% of the T cells in the body are in the skin, not in the blood.
Mm-hmm.
And there's more recently perfected single cell technology that can use formalin fixed skin tissues and get single cell data. So I would imagine many of these patients have biopsies someplace. You may actually get a better T cell signature and more insight into the pathophysiology by looking at skin for single cell and we'll look at the blood.
Yeah, I appreciate those. Those are fantastic ideas. Yeah, absolutely.
I have to tell you personally how proud I am of Reid because I first really got to know him when we were doing a skin cancer screening at a cross-border initiative. And he could speak to the patients flawlessly in Spanish. And I'm just thrilled to see how far you have come with your research and your continuing compassion for people that are not served. And I want to now invite you after the talk to come and help yourself to a Valentine in honor of Reid's talk. Because
really nice.
there's an ulterior motive to this. You know that I am the director of Camp Discovery. It used to be called California, now it's Arizona, because it will be in Prescott, Arizona. Tim Dang's cousin will be one of the counselors. Maybe Tim will be able to come too, and maybe Reid too. But I want to remind you that when these children get over this terrible condition, and they always have it hanging over their head that it may come back, Camp Discovery is the perfect place to refer these patients. Because even if they have no visible or obvious scars, they have emotional scars. So certainly as survivors of MIRM, RIME, whatever name it will be in the future, they are more than welcome. And for the scars that they have, they will be accepted and celebrated by their colleagues at camp.
After that very nice. Oh, I have another science question for you. Sorry.
Yeah, please, yeah.
The patient that you showed the single cell data for what was the inciting agent for that?
That was adenovirus.
That
So that patient was on high flow and I think was briefly intubated and then had a BAL that identified adenovirus on PCR.
It was just adenovirus, not mycoplasma.
Adenovirus, yeah.
I'm just kind of curious if when you get to the data, if you're going to find a difference between like mycoplasma induced versus viral induced, the signature there as well, just because they're slightly different inciting factors. And actually it might be helpful if there is a number of differences, if there's some overlap too, in kind of figuring out what the underlying trigger is for this. And then the kind of the second question is there like known risk factors for developing this in these patients? Other than obviously the infectious exposure, are certain characteristics that are patients more at risk? I wonder if there's some immunological difference that we could track down that puts patients at risk of developing this with the proper exposure.
Right. Yeah. Okay. Yeah. Fantastic. So to answer the first question, I think this is what makes RIME really difficult. So it's hard to prove causation, and there's different, potential pathogens that are triggering it. And some patients actually have multiple pathogens. So I think that we, of course, need more data. I'm a little nervous about what the data is going to look like, but I completely agree with this idea of trying to look for overlapping features between this, because that will help us identify different molecular techniques. And then also, we may have to be very careful with what we use, because if we are using something like a JAK inhibitor, we have to be very careful to make sure that we're treating or covering for in different infections. So I think identifying a pattern will be very valuable, and hopefully we can have a short list of biomarkers to get a sense of what's happening or guide therapy. But that is of course a very important question to ask for the RIME patients. Is there's definitely going to be some variability in these patients. So more data is needed, and I think I have to be very careful with what I do with this data, like who I present this with, and that's why I'm very sort of careful with the way that I say this, because I don't want providers to necessarily jump on JAK inhibition right away. I think we need more data so far. The second question about some different predilection. So I think we do need to do a lot more research, and that's where I think the whole exome sequencing is very important of some of these, not only are the affected patients, but also the parents, to do trio analysis using and to look for different patterns. If we can, the idea would be is maybe we can identify HLA markers, because maybe the bug is acting almost like a medication does in drug-induced SJS. So maybe there's an antigen from the bug that's interacting with an HLA, but so far the HLA research hasn't really panned out in the world of RIME, probably because once again, there's heterogeneity in the different causes for this. But HLA-B27 has been mentioned to be potentially associated with increased risk of recurrence, but talking to some of the expert clinicians that have seen a lot of RIME, that have actually tested this, specifically in Canada, talking to Michelle Ramin, it hasn't really panned out in research. But fantastic question. Some of these patients may have SNPs associated with some interferons, or maybe they have an exuberant interferon response. And that's where I think understanding this and doing ex vivo studies will help inform that. But hopefully the whole exome sequencing can give us some variants of significant instead of variants of undetermined significance.
Hi, sir. Thanks very much for your talk. I was just wondering, in terms of testing these patients and testing the blister fluid, do we see high levels of CXCL9 in blisters caused by other conditions?
So I've personally, now when I see patients with blister, I'll actually take an 18 gauge and I will get samples. So I don't have a good N to answer your question. I don't have a good number of patients to answer your question. But in blister fluid from SJS and TEN, the CXCL9 and 10 are really through the roof. And recently I sent CXCL9 level on the serum from a DRESS SJS overlap patient, and it saturated the Erupt panel. It was above 2,000 picograms per milliliter. Actually, this is something maybe you can do at your center, but I don't actually send blister fluid for CXCL9. I don't send that out to Erupt because I'm worried that they would think it's too crazy. But I think, you can maybe make that justification for patients. But what I do get is I get cell counts on blister fluid, and I now you can order that pretty easily. You just take the syringe and send it, just tube it over to micro, and you can get cell counts. So I think that's a little bit of a proxy for cytokines.
This is me giving you the hook so we
Yeah,
can take our
yeah.
department
Okay.
picture. Great
All
job.
right, thank you.